I think.
It is time.
It's going.
Time for the Auburn Medical Group to be live on the interwebs. So we are coming to you live from the Auburn Medical Group. Dr. Mark Vaughn and
Dr. Gwen Vaughn.
And we are here to talk about the big C.
Cancer.
Which...
Wasn't that a show at one point?
The big C?
Yeah. I think that was the title of the show. Where somebody... Anyway.
Are you sure it wasn't SEA, the big C? And it was a soap opera?
No.
No. There was a television show about cancer?
I thought so.
Really? Was it good?
I didn't watch it. I don't really watch TV.
By the way, we
Anyways.
do have the capability of our people watching to call in using the phone number that you see along here. Or there.
Higher. There you go.
Anyway, so you can call in. Those of you like Lindsay Antwine who called in using that very number. And when we had Bianca Dye, I believe, was it Bianca Dye who called?
I believe so, yeah.
She didn't actually use that number, but we were using a different system. But she called. Anyway, but this is the number now. And we are talking about cancer. And specifically, the title is, Doctor, Do I Have Cancer? So we're talking about how do you find that out?
Right.
How do you go and find that out? So screening is the word that we want to apply to today's show in reference to cancer.
Yep. So when people, I can tell you that it's not that often that somebody comes in and their specific question is, do I have cancer? It happens on occasion.
I thought it was a great title.
It is, but it is a great title.
Push
it's
very
very
over the top.
Provocative.
Oh, speaking about over the top.
Yeah. Oh, yeah. You have information.
We have had 100,000 views of videos on the Auburn Medical Group channel.
100 million. He said 100,000. 100
Oh, I'm sorry.
million.
We have 160,000 subscribers. By the way, if you haven't subscribed, hit that subscribe button and then show us some love by hitting that bell icon so you know when we put a video out. And that's the only way really you can catch a live video. Otherwise, how would you know? Unless you actually see this pattern of, every Monday at 4:30 p.m. Pacific time, they do a live.
That's kind of weird. It's almost like they schedule it or something.
We're almost regular. It's like we're almost Metamucil.
Never been compared to that.
Never been compared to.
I don't think I have.
Those big, tall. Oh, I'm sorry. That's heightism again.
Yeah.
What is it you always get asked?
To reach for something on the top shelf.
It's heightism, you people.
Yeah.
Just because he's tall.
Don't hold it against
Don't
me.
assume that he can just reach for things.
Yeah.
Sorry about that.
Oh, Tracy says, miss you, Gwen. I wasn't here last week. I missed me too. I was on vacation.
What was the deal last week that there was like nobody watching last week? And Dr. Gwen wasn't on.
Watching. Because I was on vacation. And I still took the time out of my day to watch your video.
Thank you. I appreciate you spending your vacation watching me alone with this face, not having many viewers, because this wasn't here. This big, tall, I'm sorry.
Heightism.
It's like all I can see is his height.
Yeah.
You're not a person.
I'm a person here. There's more to me than my height.
My eyes are up. Oh, wait.
Yeah. Oh, man.
Sorry. Nice socks. So thank you for joining us. And I hope you don't feel like this was for nothing yet.
Well, here's a question.
We're going to look at your comments. Because this is live, we're getting the chat right now.
Asks, hi, Doctora. Well, we're Doctor.
Is it in Spanish?
Anyways, any big fan of your page. From 1 to 10, how difficult is finding out that a person has cancer?
From 1 to 10.
Is the question how difficult is it to find cancer?
The first
or how
cancer
difficult
or the 10th cancer?
is it to give the news and have a patient find out that they have cancer?
Oh,
those are different questions.
I love the way you take the viewer's question and turn it into the question you want to answer. You should run for office.
That's right. Let me rephrase that. I'd like to answer your question, but first let me talk about my views on the economy. Is that how you do it?
You're ready. Vote for Gwen.
Oh, man. Anyways. The big C word is definitely scary, says
Wait,
Pamela.
are we going to answer his question?
Oh, yeah, we are. I'm just reading
He's using
stuff.
the chat
People are
while we're
saying hi.
live and interacting with. That's true. We want to say hi to everybody.
To Jesus, Tracy.
Can I say hi to everybody? Like
Bianca,
the global.
Laura, Lisa.
Bianca's there.
All
Good.
of our
regulars.
We appreciate. What are you
Excuse me, I dropped the phone.
doing? What are you
We
doing?
won't
over
hear if you call.
But the big C is definitely scary. So let's talk about
Big C.
how hard it is to find cancer.
Okay, we'll hear them if they call now.
So screening. Back to that big word you were talking about. What do you mean? What is screening?
Screening's a big word.
If you're
It's
in
2 syllables.
second grade, I don't know. But that word you were saying,
Screening.
not big word. Yes. What do you mean
Topic.
by screening?
Screening. Okay, yeah, let's talk about that. So, okay, we have a slide.
Ooh.
Don't get too excited. See, I made this.
I saw that.
So, screening. When I'm talking about screening, and this will be for our definition for the rest of the show, screen, in this case, we're talking for cancers. And I want, you notice I said plural, cancers, because people talk about a cure for cancer. We've got cures for cancers, plural.
Certain ones, yeah.
Yeah, we even have a vaccine for cancer, a cancer,
Yes.
HPV.
Yeah.
So we want to be specific with what the cancer is that a particular screening goes toward. So with that,
Yep.
what makes an effective screening test? If somebody comes in and says, hey, doctor, we never really answered Jesus' question. I want to, maybe we will in the duration of the show.
Yep.
I want to know if I have cancer because I'm very concerned about it. When that comes up, we of course want to know, well, why are you concerned about cancer? Is it because a family member had a particular type of cancer? And is that particular type of cancer one that may be familial?
Hereditary, yeah.
Is there possibly extra testing we do beyond just plain screening
Which
for this
we do
patient?
sometimes.
Which we do sometimes. So for general screening, here we go. This is low internet upload speed. Continue broadcast.
Somebody was saying that it was
We're cutting up.
pausing
Okay.
intermittently, so hopefully...
Probably because of all the people on our Wi-Fi watching the Auburn Medical Group YouTube channel live.
It's all of the people.
So if you're using our office Wi-Fi,
Come on.
ask yourself, should I be doing this right now when they're having difficulty with the bandwidth? I want you to think about that question. Notice I'm not saying any names.
I'm going to get a text very soon here.
Okay. So...
Anyways, back
So
to
screening, here we go. This is what we're talking about. An effective screening is something that will allow us to have early detection,
Yes.
meaning,
You catch it at a point where you can actually do something about it.
right, yeah, you want to catch cancer when you can, and or before it's causing all the damage. That's ideal that you would do that. So that's a very important point.
Yes.
So that's why we start screenings early.
Yeah, right. At certain ages, which are specified.
Yes.
Yeah, and that we adhere to. Now, and for the general population, there's usually a certain level. If
Certain
you have
age.
certain risk, age, if you have certain risk factors, sometimes that's a little earlier.
Okay. All right.
So-
Let's talk about something else then. So effective screening, you've got early detection, and you want it to be something that effectively decreases mortality or death from that cancer, because that's what cancer does. It kills people.
Right.
So we want to make a difference in it killing people when we do it.
What
So-
about? I'm gonna push back a little here. What about morbidity? What if a cancer
Oh, yeah.
causes maybe doesn't kill you, but really causes a bad health problem later?
that would be a reason to
That
go
would
looking
still
for
be
it
a
too.
reason. Right.
And I think that's going to come in later. But really, because it's deadly, that's the biggest thing.
That's the big one. Yes.
Morbidity is something we do need to talk about, and it does need to be addressed. And we do want to catch cancers that cause bad things to people without killing them, which that's kind of being covered by the screenings anyway. But I will say the definition that I got from and that's what the link is in the description, the
Cancer.gov.
National Cancer Institute.
Oh, that one.
Is that
There's
what
a couple different ones.
Yeah, I think it's National Institutes of Cancer, or it's the NIH's cancer division, whatever you call it, National Cancer Institute. I think that's what it's called.
Okay. It's in the description.
They have a definition that just goes straight to mortality or death from it. So it's early detection, decreased mortality. So early detection, wouldn't we start it as early as possible? Well, not if it's going to not make a difference. See,
Right.
cancer is something that comes along as you live. It's not necessarily there all the time doing its thing. It's because of a change in how cells behave. So it's really not effective to go screening before you're going to have much of that change occurring. Otherwise, you're going to be screening everybody, but hardly getting any cancers found.
Right.
And that kind of makes the screening a little useless if you're not getting any results from it. So that's why we're not screening 5-year-olds for colon cancer. We're just,
Right.
I'm not going to say it's never happened, but for it to be worthwhile to go screening, you want it to be something that you're going to save some people.
Yep.
So the other thing is you want your effective screening to be something that the benefits outweigh the harms
Of the test.
of the
Is that
test.
what you're talking about?
The test's benefit outweighs any potential harms of the test. So what's an example of a test that causes harm? Well, probably any of them can.
Right. Yeah. A colonoscopy can cause harm.
A colonoscopy
There is
can
a
cause
small
harm. That's right.
small risk of perforation, but that risk is so rare that the amount of times it works well and we actually find cancer outweighs those risks. So,
Okay.
So there's something. The obvious one that comes to mind is the PSA. Doing a PSA check, which we'll
we'll get to
probably
later,
get
yeah.
to, can lead to a lot of unnecessary procedures that can have some harms.
So on this list of criteria of a good, effective screening test for cancer, we will find in a little bit that the PSA, or prostate-specific antigen blood test for prostate cancer, has actually been removed from the list of effective screenings based on that criterion of
Right.
harms are outweighing the benefits in its case.
Mm-hmm.
Because it's harmful to go testing everybody that has a positive PSA because
Right.
it's just too common, because it's not all that specific.
Right.
Yeah. Okay. So let's talk about some specific cancers and their screenings that
Okay.
we actually have and we can do. So some effective screenings would include these 4: colon cancer, lung cancer, breast cancer, and cervical cancer.
And those are done by colonoscopy. For
Yeah,
colon
let's talk
cancer.
about it. So colon
Now,
cancer.
there are a couple different ways to screen for colon cancer, and it's proven that all of those are effective.
Okay.
So the 3 main ones, well, I guess we can maybe lump in there sigmoidoscopy, but no one's really doing sigmoid. I don't really do it.
I've heard that there are
sigmoidoscopies
some
anymore.
big box organizations that
Still do that.
that do sigmoidoscopies.
If you're going to get that done, might as well do a colonoscopy, in my opinion. But anyways.
Yeah. Let me just throw something out. I'm sorry to interrupt you. Throw something out about sigmoidoscopies at the big box place.
Yeah.
If you are getting scheduled for a sigmoidoscopy, think about this. You're going to have to come back in 3 years to have it done again. You may not have as much sedation as you would have if you had a full colonoscopy. You're not having as much real estate checked for colon cancer as if you got a full colonoscopy. So you might as well just go ahead and get the full colonoscopy, be sedated to the point that you're not going to come away from it with a really bad experience, and be more thorough in what they find and take care of. May not even have to come back for 10 years, depending on what they find, instead of 3. So just that's kind of my view of colonoscopy versus sigmoidoscopy. A sigmoidoscopy is kind of nice in that it can be done in a primary care doctor's office. So your doctor who you know does it instead of somebody they refer you to. Yeah, that's nice. And it's nice for those primary care doctors who are able to have that procedure in-house, which is kind of nice. I mean, it's able to keep more and not send it all out everywhere else. So I'm sorry, I interrupted you when talking about colonoscopy.
I was just talking about the 3 main ones that we've used. So colonoscopy is one that's the gold standard, because while in there, the gastroenterologist can actually take or biopsy and remove precancerous polyps. So that's the gold standard. That's the best one.
In these tests we're talking about, it's the one that actually can prevent cancer.
You're right. Yeah, you can remove
while screening.
precancerous polyps. So that's one. Then the other two are stool tests. The one is the 3-year Cologuard test, and the other one is a stool test for blood. Those are the acceptable tests. The stool tests, if they're positive or come back showing an abnormality, you actually need a colonoscopy anyways. But there are some new studies that are saying that stool tests are actually not that bad. They're actually very cost effective and still find cancer at a very high rate. So there's some more research to be done.
We've had a change in what the stool tests are. It used to be that a stool test was a guaiac test that did it just check for heme or for iron? It's something that you get a lot of false positives with. And these new DNA or fecal immunohistochemical tests, FIT tests, for blood are much more specific to blood, a better screening. And then there's the even better one that you only have to get once every 3 years, the one that's for the DNA in
the cancer.
The cancer itself. Those are the ones, like Cologuard is a commercial product that you can get your doctor to write an order for, but it costs as much as a sigmoidoscopy at this point.
It is expensive, yeah. So the most cost-effective one is actually the stool test.
Which is what we're doing. Do it annually. It's a lot easier to do than a colonoscopy.
For those who have had previous polyps or something like that, I will do a colonoscopy. Yeah, that's a good one. And it's not a bad idea to do that when somebody turns 50, just to get a baseline.
Are you sure you want to say that right this year?
How old are you?
I've been telling everybody colonoscopy's the way to go. Colonoscopy's the way to go. That's what I'm going to do when I turn 50.
Then conveniently.
Dr. Gwain finds this article about how good the stool tests are that are out now.
Man.
And maybe you should consider those. I might be changing my song when I turn 50.
Boy, that's really going to be a bummer for videoing that live. Man.
Oh, yeah, because it's not going to be as interesting to just... Yeah.
Well, I guess we don't.
Instead of the whole colonoscopy. Yes, we do have to figure out a way to get that on the YouTube channel live. That would be good. We'll have to see if one of our colonoscopy specialists.
Gastroenterologists. Anyways.
Moving on to
the other cancers.
Why do we want to find colon cancer?
Because it's treatable.
It's so treatable. It's like the skin cancer of your insides.
Yeah.
I really do talk about in those terms.
I've never heard it called that, but
Okay. How dangerous is skin cancer? Well, malignant melanoma is pretty dangerous and it spreads, but it's right there. You can see there's something suspicious on your skin and get it looked at and taken care of, hopefully before it comes. And the other types of skin cancer, like squamous cell carcinoma, that really can be a bad cancer if you have it internally.
Yeah.
You can see it right on the skin and get it taken care of before it's a problem.
Right.
We can do that with colon cancer. It's right there on the surface, except you have to go inside to see it. So it is the skin cancer of your insides.
Yeah.
Colon cancer. We can beat it. And that's the other thing about colon cancer. I tell people, if everybody got colon cancer screening as recommended, you'd be hard-pressed to know someone who died from colon cancer.
Right.
As it is, most people our age and older know people who died of colon cancer.
And usually
we can change that.
Yeah, because it was found late.
Yeah.
Because they didn't get their screening test done.
Yes. So that's why I'm a big believer in colon cancer screening. Next one. Let's show people what the next one is so that they can follow along at home. And that would be
lung cancer. Now, lung cancer isn't the general population. It's just an effective screening for a certain population.
It's a very specific one, isn't it? I was a little surprised to see that on the list on the National Cancer Institute as one of the big four. You know, I always thought of the big three.
Right.
They had it the big four, and they included this one.
Right. And that's in people who have smoked.
Smoking history. A significant smoking history. I believe they have an actual amount.
How many pack years?
Like 30 pack year history.
That sounds about right.
30 pack year history. So you take the number of packs per day and multiply it by the number of years smoked. So if it was a pack a day for 30 years, that would satisfy it. If it was 2 packs a day for 15 years, that would satisfy it. If it was a pack and a half for somewhere between 15 and 30, you do the math. Yeah, you do the math. That's algebra.
Yeah, that'd be basic math.
I'm not doing it in my head. That's somewhere in there between 15 and 30, or 15 and 30. Then there's a test. If you're between the ages of
50 and 65, right? It's not one I order all the time, so I always
55 and 74.
I always have to review it.
Yeah, I have to also. But somewhere in that it's roughly a 20-year window, mid-50s to mid-70s, that they think it's an effective test to do.
Yeah.
Why is there a cutoff at the end on all these tests?
Right, for all of them, yeah. For colon cancer, it's upwards around 80. Because at that point, the risks actually is going to outweigh the benefits of doing the tests.
Because there's like fewer years of life that we're
essentially
giving them by stopping this cancer once they get up. But that's a real generalized
it is. So you
number.
do need to,
you can't apply that to everybody because some people don't even live to that age, and others
right.
are going to go for a long time. So when we reach that age of the so-called cutoff for the recommendation, most of the guidelines say it's appropriate for the doctor and the patient to have a discussion about, is this test right for you?
Point. Yeah.
When somebody's, they know and we know they don't have another 5 years in them. Most of the cancer screenings really aren't.
Right.
Aren't
there does come a
appropriate.
Point.
Yeah. Okay, so the lung cancer it's called a low dose CT or computed tomography or CAT scan of the chest. We're looking at the lungs. We're looking for cancer lesions in the lungs. Here's the bad part about it, though. I think you have to repeat it annually to actually be screening for it because things show up.
Mm-hmm.
That's another thing about all these tests. How often do you repeat it? Well, for this one, and then another factor with this CT, low-dose CT of the chest in a smoker, most of them actually have something in them.
Right.
You don't know what it is. It's not necessarily cancer. And so you always have this follow-up. Well, what do we do for follow-up? Well, since they're recommending them annually anyway, generally it kind of falls into that's what we're doing. Some of them we get 6 months. Some of them we start considering biopsy after a couple of positive scans or if something's growing on repeat scanning.
Right.
I don't know that we typically are going straight to a biopsy with a bronchoscope or
I don't think so.
unless it was
there are
really
some very
bad.
Specific guidelines.
And generally, you'd have symptoms if it was really bad, and then it's not a screening anymore.
Yep.
It's not a screening. It's called a diagnostic study, and that's where screenings and doctor, I have these symptoms. Is it cancer? Are different. Screenings we do on everybody. You don't have a family history. You're just a male or female of a certain age. That's all the criteria. If you have other risk factors, whole different criteria we use to decide what test is appropriate for you.
Right.
Okay, so let's go on to the next one, which is, or do we have any comments appropriate?
Plenty of comments.
Oh, maybe we should answer some of those comments.
Well, people are just talking about their colonoscopies, and some people had some other
always an interesting
sigmoidoscopies, and they said they weren't out for, I don't know who it was, it said they weren't out for their sigmoidoscopy, and it was a horrible experience, which makes sense.
Yikes.
And then, some breast cancers, people telling about the cancers that were found in their family members or in them. Some people having some follow-up mammograms.
Okay. And I'm sure we'll probably have some of these. Boy, that's a lot of comments.
There are a lot.
Thank you for participating. They're kind of having their own conversation.
Yeah.
We're building community. One of the things you'll see often is somebody having a test that doesn't necessarily fit the current recommendations for screening, and it caught a cancer.
Right.
That does happen. But we wouldn't recommend it based on the wonderful story for a person who did get it caught with the test being done outside of the current recommendations. We wouldn't recommend it for everybody in the future because you're a statistical anomaly.
Right.
That it worked out for your favor. If we were to do it on everybody on these recommendations when that's not recommended, it would end up costing a lot of money, putting a lot of people through. The benefits versus the harms. We didn't get into a lot of detail on that.
Yeah.
But like biopsies that weren't necessary, we were just talking about lung cancer. So these nodules that are found, some of them we don't know what they are, and it does lead sometimes to either a bronchoscopy or open biopsy of the chest. Hey, there's some morbidity and mortality to that. Morbidity being some people actually have injury from it or get hospitalized or miss work because of a test that maybe shouldn't have been done in the first place if we were to limit it judiciously. And mortality. Given enough of them, and these procedures generally do have small but some risk of death to them. When somebody does die and it was a procedure that maybe we didn't have to screen everybody with that particular screening, both sides have to be considered. There
Right.
is not a no-lose situation to cancer screening. No, some people can get hurt.
Right.
All right.
Yeah.
So the next one would be
Breast cancer.
breast cancer. Okay, how do we screen for
With
breast cancer?
routine mammogram. That is the
That is
test of
the
choice.
test. That is the test. And what we're going to find out later is that it's not necessarily breast MRI for everybody.
We need to hold that off till later.
That's right. Okay, we'll get to that later. So in speaking about
Anyways,
breast cancer screening, you said mammogram.
yes.
And there has been a change in recommendations by the American Cancer Society and the National Institutes of Health. And you'll see it at the link we put in the description at the National Cancer Institute. And that is in women, what age is it? Is it 40 to 50? They don't recommend every single year, or is it 50 to 75?
It's 50 to 75.
50 to 75.
And then 40 to 50 is a conversation about whether or not you should get them.
Okay. So 40, starting at 40
Yep.
is generally what they're saying. But at 50, not every year, maybe every other year, or having a conversation about it.
Right.
So I lean towards every other year instead of every year. And the reason is because of the hardship that it is on the patients who get the so-called false positive.
Right.
There's a term I'd like to introduce here. And I forgot it because I'm old.
Which term?
Overdiagnosis.
Oh, gotcha.
Overdiagnosis. How can cancer be overdiagnosed? Don't we want to know about all cancer? We don't know.
Yep.
There does seem to be a concept of overdiagnosis where a cancer is discovered and the knowledge of that cancer being present is actually bad instead of good. How can knowing there's a cancer be bad?
I was reading, so I didn't hear the whole question.
So
Sorry.
cancer can be, the knowledge of somebody having a cancer can be bad if it leads to them being stressed, if it leads to a procedure being done that doesn't make a difference in their longevity.
Yeah.
And that's actually a place where we are now in medical science, at least in our country, where testing can actually be overdone to where it's not adding further benefit to the patient, but worse. So that's another reason we back off to the every other year on the mammograms, is because yes, we are saving a lot of lives, and that's another thing. We are saving a lot of lives with mammograms.
Yeah.
But there is a cost being paid for it, and that is the people who are being treated for things that maybe could have been watched or discovered later.
Right.
Strange concept. How can it be bad to find cancer? But it's because the knowledge of it and the following of it can lead to problems.
Yeah.
Okay, so breast cancer, we said mammogram. We didn't
talk
say
about any
MRI.
other.
We didn't say breast exam. All right, let's move on to the next cancer, which is.
And actually, somebody has a question.
Oh, what's
It
the
says,
question?
Is there a percentage of how many positive cervical cancer tests are false and positives?
Yes, there is.
There is.
I don't know
some statistics on that.
There
I'd
are.
have to look it up for
We'd
you.
have to look it up.
But yeah, there are some, and that's actually what drives the frequency at which we get those tests done.
Yeah.
Because if we did them more often, we would get more false positives, but we kind of lengthen them out. And actually, moving on to the cervical cancer that we're talking about now,
Yeah.
it was only recently, maybe 5 years ago, that they
we changed them.
lengthened that out.
Yeah.
And that if you have a Pap test done with an HPV and both of those are normal, you can go 5 years between
5 years.
your Pap tests. So
Used
it
to be
used
every
to be
year.
yearly,
Every
or
single year.
then it went to every 3 years. Now it's every 5 years. So yeah, they're lengthening it out because of this exact reason, that they were finding a lot of false positives, and they actually found that if you do not have HPV, that virus that causes cancer, your body will actually clear a lot of the changes that happen in those cells.
So there's two tests. There's the PAP and there's the HPV, which is looking for the human papillomavirus, the virus that causes cervical cancer. And you want to get both checked. Now here's the weird thing. We don't start checking for HPV until age 30,
30.
somewhere around
It's
that.
at 30.
Why is that? Well, if we find it, and here's the funny thing, HPV is sexually transmitted, so it's actually more often being transmitted at a younger age, but we don't go looking for it there because, strangely, our bodies can actually take care of it, get rid of it.
Yep.
So a person can go from HPV positive to HPV negative by the time they're 30. So we don't even start until they're 30. It's possible that you're missing some cervical cancer in younger patients. It is possible.
Right.
But again, it's this whole thing about, yeah, but if we got all those positives, there'd be an awful lot more patients that we're suggesting operations to and other treatments that may be detrimental to a large number of the people receiving them. So
Right.
it's hard to make these judgments and these cutoffs between, okay, where do we? And that's why we look to the NIH and the National Cancer Institute and the American Cancer Society, where people who study this a lot more than we have time to come up with these recommendations. Okay, so that's cervical cancer. Every 5 years.
Yep.
If they're both negative, if you don't have family history. Okay, so let's look at some other.
Well, it's actually 5 o'clock.
It's 5 o'clock.
And my
you gotta
daughter hit her head.
She hit her head. Okay.
So I need to get going.
So can we tell people real quickly about the
not effective
screens?
Very quickly.
So alpha fetoprotein is one that's used in liver cancer, but only if we have reason to suspect you have
not in
liver
everybody.
cancer.
Yes, if you have like hepatitis C or some liver hepatitis, something like that, then we do check for it, but not in the general population.
Breast MRI, people who are BRCA1, BRCA2 positive.
Yep.
That's also true for,
but not routinely, because the mammogram is a better way of screening.
yes. And CA125, ovarian cancer.
Ovarian cancer. Ovarian cancer is one of those where, unfortunately, we should not. It's so rare that we should not screen everybody. Now that being said, the general population we're talking about, those with BRCA abnormalities should be, but not everybody.
Okay. And then
clinical breast exam.
Clinical breast exam and telling patients to do their own breast exam has actually been
really not needed.
No longer a recommendation. If we find something, we go check it, but we follow it up with mammogram. Okay, PSA, we talked about PSA. We talk about PSA all the time. Don't get screening PSAs unless you have symptoms or some other reason. Skin exam. I was surprised to see they don't recommend looking at people's skin.
I don't. Well, I guess I was trying to think about downside to that, but I guess it would be biopsying something that
biopsying everything that you can find, which we know of doctors who do that.
Yeah,
and that's not necessarily effective.
I don't biopsy everything. It's got to be looking really funny.
Transvaginal ultrasound, certainly not a screening test for everybody who comes through the door.
Yeah.
Maybe appropriate people with certain family histories or
bleeding.
Yeah. If you have something
then
going
you can
on.
have it done.
And then I put virtual reality. It's not actually virtual reality.
Virtual reality colon.
Virtual colonoscopy. That's
I was going to say, whoa!
I think they call that.
That just sounds awesome.
A CT.
But
it's like a ride. You can look all around.
I'm going all over your colon.
Virtual reality.
A virtual reality colon.
Thank you for staying long enough to follow up on that last list there. Sorry we can't get to more questions. We had a lot to pack into today's show, and we thank you for coming here. We thank you for subscribing. And who do you want to thank?
Boo Boo Kitty.
Yes, thank you, Boo Boo Kitty.
You make this happen.
And also thank you to Lindsay Antwine, who helps with the Auburn Medical Group YouTube channel. And we have Patreons. You have one. It's patreon.com/
Dr. Green Knight.
And I have one that's patreon.com/ Auburn Medical Group. And that's how people get their names out there if you're interested in that.
Yep, check it out.
Until next time.
Dr. Gwen Vaughn.
And Dr. Mark Vaughn telling you to stay in good health.
And we'll work on that virtual reality colon for you.
We'll have to work on it.